Hello guys, my name is Aurora Powell. I'm a fourth year medical student for anyone who doesn't know me. Whitney and I have worked on this presentation and it's basically an integrated case presentation, a little bit different than what you would normally get for a case presentation of a patient. We have a little bit of medical stuff mixed with a lot of social stuff. And we're just making it it's a real patient, but we made it a little bit hypothetical so we can get an idea from all these people what they can help us with and what we can contact them about. And so the point of this presentation was when Whitney and I had talked to each other, we had talked to other students and realized that a lot of us had no clue what options were in the community. We didn't know what each place did, and we didn't know how to refer to them. So we think it would be useful as students to have an idea of what things are in your community, exactly what they do and what things they offer, and then how you would refer to them. And so with that being said, let's start with our panel. If you guys could just introduce yourselves and where you came from.
My name is Tanya Plale. I'm the therapy coordinator at Slim Pines Adult Care Center. It's a long-term care facility. I have over 20 years of experience in therapy in the area, so I can answer any questions or try to get you to the people to answer the questions as far as resources in the community or what ifs. How, in my experience, I would put somebody through the continuum of care, whether it be long-term care, home health, outpatient. I also have dealt with geriatric clientele personally with my grandparents, and now my parents are starting to have some health issues, so I feel like I can see both sides of it sometimes when I'm thinking through with people, so yeah, just here to help out.
I am Wendy Besler, and I am the Director of Nursing at Slim Pines Adult Care Center. And I've been with Slim Pines for 24 years. And so again, I've kind of been there seeing kind of the gamut of things, trying to help people meet their goals, whether it be go home or if they need long-term care and what that type of long-term care will look like for them to have the best quality and quantity of life within a skilled nursing facility.
Okay. I'm Bev Howard. I'm the Director of Case Management. And essentially what our role is to establish a discharge plan on admission and work the way through that onto the continuum of care, be it home health, nursing home, or directly to home.
And I'm Chad Earhart. I'm the Director of Spiritual Care and Volunteers here at the hospital. I've been here at Kirksville for about 5 years and have 4 units of what's called CPE, which is Clinical Pastoral Education. And it's kind of the way that chaplains are trained. So chaplains kind of deal with spiritual care, with not spiritual counseling, which is kind of looking at a person's past and giving them prescription for the future, which would be more counseling. It's more spiritual care, which is usually dealing with the emotions and the thoughts and the beliefs of a person in the present. So if they're anxious or worried or addicted or concerned or wondering why, all of those kind of things are the things that we tend to deal with.
I'm Angela Caraway, Chief Operating Officer at Mark Twain Behavioral Health. We're a community mental health center in Northeast Missouri. We have a lot of long-term programs for individuals that have severe and persistent mental illness, but we also do some counseling, and we work with the hospital when clients come into the emergency room in crisis and make referrals from there. We work a lot with law enforcement and judges with clients that might interact with that system as well. And we have kind of a huge push right now for integrated care, whether it be if the client has a mental health condition plus a substance abuse disorder, or they have some comorbid medical conditions going on, kind of a healthcare home medical team philosophy with that as well. So.
And I'm Stephanie Byram. I'm the Executive Director at Hospice of Northeast Missouri here in Kirksville. However, we serve 11 counties in Northeast Missouri. And we focus on end-of-life care and palliation of symptoms at end of life, focusing on holistic quality of life.
All right, thank you guys. So we'll get started with the case then. So, like I said, we'll have just a little bit of medical stuff and a lot of social history. So this is from his original H&P. So MT is a 77-year-old Caucasian male who was brought into the ER from a nursing home on October 18th for dyspnea and O2 saturations in the low 80s. Patient has a history of chronic respiratory failure with severe COPD, coronary artery disease with a 5-vessel bypass at University of Missouri Medical Center, and 1 stent implant after, severe peripheral artery disease, and pacemaker implantation. He uses a walker but is mostly bedridden at the nursing home. He has had an increasing shortness of breath in the last couple of days. Patient states that he has had shortness of breath for, quote, a long time. Patient lives in a nursing home and his daughter comes to visit him frequently. The daughter states that the patient was doing fine on the 16th, and when the daughter came to visit again on the 17th, the nursing staff stated that he had a panic attack that day. He was not breathing well when the daughter visited, and he was placed on BiPAP. On the 18th, the patient's oxygen saturation was in the low 80s, and he was sent to the hospital. So as far as his social history goes, he used to smoke, but quit about a year ago. He smoked for 58 years, about a pack and a half per day. No alcohol. He's widowed, has 3 adult children, 2 boys and 1 girl, that all live within a 3-hour distance, and has several grandchildren. Occupational status, he worked for the State Highway Department for 30 years before retiring, and then he worked at the Lancaster Flower Shop. He lives at a rural nursing home and has no military service. So social history continued. The patient is currently living at the nursing home in a small town. He moved there in January of 2015 because he had a hard time getting around and completing his normal activities. He uses a walker and his oxygen desaturates very quickly when he exerts himself. He is there to have physical therapy and regain some of his strength so that he can go home again. So life at the nursing home. There are many activities at the nursing home, but he doesn't like to participate in many of them. He says he likes to watch TV, especially Westerns. He does physical therapy at the nursing home, but no other services. He likes car racing and used to go watch cars race in Kansas City. And then his daughter visits him a couple times a week, although he would love to see his children more. So his spiritual life, he affirmed that he is religious, but he hasn't gone to services since he went into the nursing home. And he states that there are services there. So this was his initial assessment of why he was in the hospital. Severe sepsis with right lower lobe pneumonia. He also had acute on-chronic hypoxic respiratory failure, critical limb ischemia, acute exacerbation of a severe COPD, diastolic heart failure, hypertension, coronary artery disease, dyslipidemia, secondary pulmonary hypertension, chronic AFib, sick sinus syndrome, GERD, peptic ulcer disease, and major depressive disorder. So he had a lot of things going on.
What was that last one?
Major depressive disorder. So he has a lot of things going on, and some of these things, we know he's gone a certain way in his healthcare, but we're going to say hypothetically he gets better or he gets worse, and that's the point of the panel, is to see, how we would help this patient in different situations. So let's say that he gets to go home. So say he's well enough and he gets better and he's able to go home instead of going back to the nursing home. How would we make that happen with, spiritual care, his mental health, and just getting him home so he can walk around?
Well, that would probably be me.
Yeah.
Well, providing he has insurance that will help cover. We're going to inquire about his insurance. We're going to be monitoring his care every 48 to 72 hours to make sure that medical necessity is met. We're going to get him, we're going to talk to him about a discharge. I'm shocked that he's going to go home straight away.
Hypothetical.
Mm-hmm. So what we will do is discuss with him a choice for home health. Maybe get some PT in the home, OT in the home. We will look to see if he has an appropriate walker. Even though he had a walker, was it an appropriate one? or was he just borrowing one from the nursing facility? We'll look to see what, if possible, we can purchase one or obtain one from Rail, which will give him one for as long as he needs, as long as he gets home. Talk to the daughters and the children to be sure, or whoever's DPOA, be sure that home is appropriate and he can safely go home, that there's assistance if he needs it, there's heat, air conditioning in the summer, whatever might be the issue. Talk out here, don't you?
You mentioned Rail, and I've
Yes.
heard that mentioned a lot, but I am like unaware of what that was.
Rural advocates for independent living. I just don't think they're independent. What that's going to do, what they do is they have certain equipment and assistance that's available, providing equipment provided. A lot of it's been donated to them. They have extra commodes, they have extra walkers, they might even have a hospital bed, maybe a crank type, but it would still be a hospital bed. They have some assistants that can come in to help with cooking, house cleaning, that kind of stuff.
They built wheelchair ramps.
Yes, they do.
But they have to meet criteria. They have to qualify for Medicaid to build the wheelchair ramp. So, and sometimes it's not that they build the wheelchair ramp, they will come up with the funding to provide to the family, and then the family has to find somebody to build the ramp. We used to have a list of people that in the community that, you know, they would be willing to build ramps. The last person though that we encountered, though, they just provided the money. They did not provide any kind of, like, tell them who to go to.
They've also had assistance for hearing, like phones that will augment both voice and the ringer on the phone, with a variety of technology to assist as well.
What we always do, even from our level, is even if they don't have Medicaid, we still go ahead and make a referral to Rail, because government programs change all the time and fundings get moved around all the time. So sometimes something's out there that, you know, is new that we don't know about. So we always make the referral and let them decide if they're going to qualify. And they'll send somebody out. I don't know if they ever come to the hospital, or they probably just likely would meet them at home. But yeah, you can still make that referral.
Then prior to discharge, we will look at medications, be sure that he can afford his medications. If he needs help, we'll try to obtain help, some sort of assistance through some pharmaceutical company, or, and then we set the discharge date and transportation home.
I just had a question though. It never mentioned anywhere what his code status was.
Right. I can't quite remember what it was. We just had minimal information. So,
Make it up.
yeah,
What would it
we'll say he's full. He's
Full.
full. There we go.
That's typical. That's
That's
typical. Yeah.
Why not?
Do whatever it takes.
Yes.
All right. So we also answered kind of what if he was too weak to get around. That's kind of.
Hey, I would just add to that.
Yeah.
What I would probably do is go in, check on that patient, make sure that their whatever their emotional, spiritual concerns are. I try to deal with those. They haven't been at a church, but they wanted to. I would probably do a spiritual assessment on them, which is kind of like, do they have a faith? How important that faith is? Do they have a community of faith? And that's where they would get to the church probably. And then what kind of actions would be helpful to them, which often would be, you know, maybe the pastor just didn't even know that they were in. So if we would probably connect them to their pastor just to make sure that that church community and whatever other support is helping them.
And one thing I would like to add to that is, I'm sure with the chronic conditions that this individual might have, that might have been suggested, probably has some weakness afterwards, making sure that the acute illness is taken care of. It might be suggested that they might visit a skilled nursing facility for a short time. Discharge plans, I think, oftentimes say, you want to go to a nursing home? Well, no. That's not probably an answer you probably get a yes to very often. But they can say, you know, Okay, so you truly, you want to try it at home, you don't want to go to a skilled nursing facility. But the one thing people need to know is if they had a qualifying stay, meaning they met the technical eligibility, they do have Medicare or a managed care, like Medicare replacement program. If they've had a 3-day midnight stay, that meets the technical eligibility for skilled nursing care. And if they like discharge from an acute stay and they get home and like they make it over the weekend or a few days, a week, and things are, hours, I've seen that happen, and it just wasn't going well. As long as they return, if they want to come to a skilled nursing facility and they do it within 30 days of discharge from acute care, Medicare typically will pay. Their Medicare benefits will cover their stay. So if they thought that maybe they would qualify for some PT, OT, just a nursing evaluation, that they would be able to have their Medicare benefits cover that as long as within 30 days.
Can you describe like the differences? Is it just being in the nursing home? I'm not really sure what
Skilled and non-skilled.
If you're there's several different ways of looking at it. A skilled level of care means that they are classified in a higher acuity. They have, they require the skills of a licensed nurse or therapist providing treatment because of the amount of problems that they are having. If it's just someone there, it's for custodial care, like they just can't do their normal daily, like they can't do a shower by themselves at home because they might fall, and they can take their medications. That's kind of just custodial care. Skilled nursing care would include, oxygen monitoring, labs, wound care, making sure that a pneumonia is resolving, or if they've been in for a post-surgery, if they've been in surgery and we're monitoring, a lot of things that can happen post-surgical. Those would all take the skills of a licensed nurse 24 hours a day. So.
And Medicare pays for that. Medicare or a Medicare supplement will pay for skilled care. They will not pay for custodial care.
So under your skilled care, you have up to 100 days that are covered. You can't guarantee those days because there's all kinds of criteria and hoops that you have to jump through. But what I would do from your standpoint is if you had a patient that had a 3-day qualifying stay, let your long-term care facility decide if they're going to meet criteria and then what level that they could put them at. Every nursing home under the sun wants a Part A stay because you get paid better. So then what they're going to do is they're going to give, or we give the patients the benefit of the doubt. I mean, as far as I'm concerned, from the therapy standpoint, everybody deserves to get better. Even if it's just, now I'm going to walk with 1 assist and not 2. I mean, that's still getting better. So, I mean, we give people the benefit of the doubt. That is their benefit. They have paid into Medicare. So we try to skill anybody that we can that's appropriate. But like, as long as they've had the 3-day stay, let your discharge planners and your nursing homes get into the nitty gritty of what they qualify for, because those rules change all the time.
And we always have 2 options. Plan A is always home. They always tell you.
Even
always
us,
home.
always home.
And we said, I want a plan B. That's what we asked them. What's plan B? Are you sure you don't want to go to a facility for a few more weeks, get a little bit stronger, and that way you can go home and stay home? That's how we approach the patient.
Because the things, nursing homes have changed. 20 years ago, people went to a nursing home to die. Now people go to a nursing home to get better. We can provide the intensity of therapy in a nursing home that no other setting can provide. A lot of nursing homes in the area provide therapy services either 6 to 7 days a week now. So if you go to home health, you're going to get it 2 to 3 days a week. If you go to outpatient therapy, you're going to get it 2 to 3 days a week. So even if they come, like Beth said, for 2 weeks, I mean, they can really get a lot of therapy in 2 weeks. Now, sometimes it takes longer because I don't want to discharge somebody that's on the border and they might come back. I want to just keep them a month and then have them stay at home. So they're going to the nursing home doesn't have the negativity Because everybody thinks if they get in the nursing home, they're never going home. Our first, always, our first goal is to get people home. And we do anything we can think of within the community's resource bank and the family's ability to help to get them home. So.
I just wanted to clarify on the mental health diagnosis, major depression or depressive disorder, otherwise specified?
Yeah, that's all that.
Major
that is.
depression.
Yes.
Okay. From a mental health, community mental health perspective, this individual would probably qualify for counseling, based on his diagnosis. He actually has a diagnosis that would qualify him for a more chronic program, a community psychiatric rehab. However, I feel like with his comorbid conditions, and this is really probably an individual who's kind of at the upper tier of our age range for clients that we're rehabilitating to live independently in terms of their mental health condition. So my thought is our perspective with this would probably be a psychiatric consult and counseling to start with. And then from there, if they needed more case management services, that would really only be for individuals who are needing maybe help doing their budget, independent living skills. But I feel like in this case, he's more, at the end of life, having to look at those components, and that might be more from a therapeutic standpoint and less from a case management, from a mental health perspective standpoint. Our psychiatrist would probably look at being a consulting factor on a case of this magnitude because of his comorbid conditions. We would be consulting with either internal medicine, his pulmonary doctor, his cardiac doctor, and not independently prescribing medicine outside of that realm because of the different complications that could occur and how that might interact with his other medical medications.
As far as a referral to like psych, is it different? Like, do they get in sooner if they're coming from an inpatient facility versus like outpatient if I send somebody over there to my clinic? Does that make a difference?
It would probably only make a difference if they came from inpatient psych. We've got, many of you probably know Dr. Goldman. He works, he's our medical director. He works primarily out of the Hannibal office, but he's in Kirksville some. He's probably somebody that we would kind of pull. We also have Dr. Lovey. I don't know if any of you know him from cable training. And then a nurse practitioner, Reggie Westhoff and Jeff Westhoff. So, we have plenty of providers. We could probably get them in a relatively decent amount of time. But I think the most important thing would be that consultation factor. And Dr. Goldman, I know, and Dr. Lovey both would be really open to consult with, internal medicine or cardiac in terms of making recommendations for medications. Dr. Lovey did used to consult with nursing homes, but there's been a lot of, just with the Affordability Care Act and different changes with Medicare payments. That's not something he typically does anymore. It was a lot of paperwork, I think, in the end for what he felt like his impact was. But I know, a lot of the nursing homes all have physicians on staff too. So, they have access to consult with our psychiatrists, just courtesy wise.
So what if our patient decides to discontinue his spiritual treatment and might need some hospice?
Case management would do the referral. We would discuss with the physician, contact Stephanie, and Stephanie would take it from there.
Yeah, so we get a referral, which from the hospital setting comes from case management, as Beth said. We can either come over here to the hospital and meet with them one-on-one. If it's a hospital out of area, we can do it over the phone, or if there's a family member back home here, local. We don't typically drive outside of our service area to a hospital to meet with families unless it borders just right on our service line.
give them information about hospice care. Things, again, as they talked about, skilled has criteria levels that you have to meet, so does hospice, because it is paid for by Medicare, primarily Medicaid, private insurance, and so there's certain criteria that patients have to meet. For those of you who aren't familiar, you've maybe heard the term palliative care, which is alleviation of symptoms, and so that's kind of the overall umbrella, if you will, and then hospice care is within that. It's a very specific benefit. Again, as Tanya was saying about the skilled benefit, it's an entitlement to Medicare beneficiaries. It is their right to use it. It's a good benefit in the fact that it covers all of hospice services 100%. So our patients have no co-pays, co-insurance, nothing, if they have Medicare Part A. Again, private insurances have some plans. VA pays for hospice care, and Medicaid as well. So when looking at eligibility, like the things that stand out to me with this gentleman's case, obviously his chronic respiratory failure, severe COPD, his severe heart condition, the severe PAD, mostly bedridden at the nursing home, so that's a decrease in his ADL function. He's now having an exacerbation, which led to a hospitalization. That's a key indicator for somebody at end stage when they start having, as you all have probably learned the lingo, your frequent flyers who keep coming in for the same problems over and over, and they're never really getting better. They're just kind of either here or every time they come to the hospital, they're stepping down in their level of condition and functioning. Shortness of breath for a long time. Also the fact that he was put on BiPAP and his stats were still in the 80s. Then we would also look at weight loss, appetite loss, along with the ADL function. So those are all the types of criteria things that I would be looking at, getting from case management, from the chart, from his hospital stay, and also working with his primary care provider if they're not seeing them in the facility, going to them and to the clinic and asking for records. Talking about the nursing care that we provide, telling the family about the nursing care, nurse aid care, social support through social workers, professional medical social workers, spiritual care through chaplains, volunteer support through trained hospice volunteers. We are a small hospice, so we kind of have, those are the core services of a hospice team, whereas a larger hospice may have things like pet therapy and music therapy. We also contract for physical therapy, occupational therapy, and speech therapy. So those are all options to have at home as well. The nice thing for this gentleman is that we can care for him at home or the nursing home. So no matter where he chooses to go, if he's at end stage and the physician certifies, yes, I believe he has about 6 months or less to live if he doesn't get the aggressive curative treatment. It doesn't matter where he goes. So it's a win-win for him because he can get our support services. And then the nice thing is if he passes away on hospice care, his daughter and then other children, if they need it, they're going to get grief support from us for a year after he passes away. Whereas they're not going to get any of that type of service from the provider that's in their home with, anywhere else. They might be able to get something like that from Mark Twain if they didn't have hospice care, but as far as getting it from the provider that they already knew that was working with them at home and who knows them now, that's the service that people get.
One other thing, like Stephanie was saying, they can receive hospice care in a skilled nursing facility or at home. So if the individual is not, family is not able to care for them 24/7 like that, and they would need a skilled nursing facility, there's a couple of options that they can use because, if they're just choosing to go more comfort measures, more supportive care and palliative care in a skilled nursing facility, we partner with hospice. But the other thing is, again, if they've been in a hospital and they've met the technical eligibility, and let's say they'd be private pay, they don't have Medicaid or a long-term care insurance, they can come in skilled for palliative care because, again, it's requiring the skills of a licensed nurse to assess their level of comfort, whether that's pain or respiratory stress, and it takes the skills of a licensed nurse 24/7 to provide that type of care and provide those medications, make the recommendations to the physician whether or not they are meeting their goals of comfort. So yeah, you can go a couple of ways. So this is going to be a financial burden to a family that, they can't take care of them at home, and they would need, and right, then they can exercise their Medicare benefit within the SNF. But, if they don't have any problem with that, then, having hospice on board along with being in a skilled nursing facility just gives them that much more access to, the volunteers and the support for not just the resident, but for the family as well. There's a couple different ways around that one.
I might add to that. Do they have any of you come from hospitals that have palliative care teams? Okay, so you kind of know what I'm talking about. I think like 90% of hospitals do. For some reason, we don't have a team like that, just to know, in-house. We have people that we call it comfort care in this hospital, more than palliative care. So that's kind of where things have been moving. But you can still use spiritual care, I guess, in that, and we may end up moving to that someday. We just don't have it at this stage. And the reason why I say that is because then what I would probably do in that situation is, of course, work with all the team and try to support the team as well as the patient and the family. We're trying to make sure that everybody is feeling good about those decisions. But the question that I would be asking would probably go into the why. Why are you choosing that? For instance, I was just on the floor with a COPD patient, and she's basically telling me that she feels like she doesn't know whether to continue. Maybe I should just give it all up and die, or whether she needs to figure out what her purpose is. Why am I still here? And so I'm usually kind of working through some of those questions, because I wouldn't want a person just to knee-jerk and give it all up to do discontinue. If it's other reasons, that makes sense, right? But if it's like there's some depression kicking in there, I'm trying to be aware of those things and making sure that it's just not a knee-jerk reaction. Another thing I'd probably do is work with the DPOA. She has a DPOA, but not everybody does, so I'd probably be making sure that they have a DPOA. And that usually is a question that's asked in the hospital, and that I am the person in the hospital that deals with the durable power of attorney stuff and trying to answer all those questions. But for me, what's more important than a durable power of attorney, which is the legal piece of it, is that they actually have what we call caring conversation with their durable power of attorney. In other words, I'm trying to encourage that they are talking to know what the issues are that they're going to have. So breathing tube, no breathing tube. There's all kinds of, I have paperwork that kind of walks them through those questions. And then a part of that caring conversation thing that I usually have, or that I encourage them to have with their patient, is a document that talks about types of illnesses. And the reason why I think that's important is I encourage them to have that conversation with their physician. And it's a really clear picture of the different types of illnesses that people have. So for instance, some people go along and they die in the middle of the night. Great, that's what I hope happens to me, right? And I don't have to worry about it. There are other types of illnesses in DPO, or what are we on? This is what patient? COPD patient. They may do well, and then they don't do well. And then they may do well, and then they may not do well. And sometimes that gives false hope to families, and they're trying to understand what's going on here? What's the problem with this hospital? They do well, and they don't do well, or whatever. And some clarity about that sometimes is very helpful to patients, and that's all kind of part of spiritual emotions here.
But you have to make sure that DPOA is activated. I mean, you have to be sure that the patient is incapacitated and can't make her own decisions. Or she's made the decision, he has made the decision that I want my DPOA to speak for me. There is a little trickiness there, and
Do you have to have
ethics committee. And
Yes.
I'm glad you brought that up, because a lot of
Yes.
people think that they sign a DPOA and it's automatically activated, and it is
And
not.
I'm boss now.
Yeah,
It's
and
not.
so then you get a family member that doesn't agree with the family. And I was gonna bring up a point,
Yeah, that's
and I'll
true.
bring it up now, is everybody has the right to fail. And even if I don't agree with their decision, if they don't have an enacted DPOA, we can't hold them anywhere. Doctor can't hold them anywhere. We have to let them go home because everybody has that right to fail. Now, we can call and hotline them and not let them leave the building until the Division of Family Services gets there. But I'm glad you brought that up because there is huge confusion in this community, or we see it all the time about that.
Yeah.
Well, I have DPOA, but then when we get the paperwork and we read over it, it is not enacted.
But you can't hold them either.
We
They
can't
have the
hold
right
them.
to go.
We-
They can go.
They
you
can
just-
go, and so we have to get a hold of the doctors and then Division of Family Services and let them work it out. Now, there are ways to get it enacted. If the patient truly has dementia issues and we'll get speech therapy involved and do some standardized testing and give the doctors some actual clinical hard data, if anybody ever questioned that, the decision that the doctor made to enact that DPOA. But sometimes it gets tricky because you have a doctor that doesn't feel like going out, or two doctors that feel like going out on the limb, and then you have to take it to court, and it can be very tricky.
What if it's not a safe discharge?
We call Division of Family Services and we hotline them.
Hotline.
And so the patient's held until the.
No, the patient's
We have no
held
right to
against-
hold them.
No, no.
So doesn't that put the
Only a
doctor
judge.
at liability then? If the
Only a
doctor-
judge
You
can
do
take
it.
away their rights.
So they're,
You do an AMA, I mean, they would have to sign
Okay.
AMA, they'd have to leave
Okay.
AMA, but
And
it does happen.
another piece of that too is the other side happens too, where they, and I had this happen this week as well, durable power of attorney, where they're wanting that to be done. The family's all there, they're ready to have the notary sign it or whatever, but that patient is not cognizant enough to make that decision.
Yes.
So that's why it's so important, especially as
Do it early.
physicians, that you talk about that earlier and always. I'm here in the ER every time there's trauma, and so you have a 21-year-old. I wish 21-year-olds had DPOA, but because it's like you have that situation where it's just,
and then do section 12 people?
who makes the
or-
decision?
Like a 96,
What's that?
is that what you're asking, like
Like
a
a
hold?
96-hour hold.
Where I came from, it was a section 12, if someone has dementia, like severe enough dementia, they're not mentally competent to make a decision on their own, and they want to leave against medical advice, and it was called section 12.
Then they would probably have a DPOA or a guardian, and that would be in charge of them if they've been already deemed.
So there's
that-
nothing in the state that gives a doctor a right to say that the person's mentally incompetent and
So,
that they
Well,
will-
well, I
can
mean,
you
there is,
clarify,
yeah.
were they already deemed medically incompetent, or you knew that they were not able
By what
to
they're
make
doing.
clear decisions by what they were doing?
It was clear that they were not able to make clear medical
That
decisions.
they were not declared incompetent?
There was no paperwork.
Well, and maybe their medical condition is such that they declined.
Yeah, we
Well,
don't
here-
have any way that I know of in this area. We had a lady a year and a half ago go home, and literally I was making stuff up until Division of Family Services got there, because what we also benefit that Twin Pines has, and a lot of nursing homes have it, I mean, a lot of people do a good job, but we will take them home and do a home eval. So this lady, she was 51st dates on her memory, I kid you not, 96, living at home alone, no family, or maybe the daughter lived way far away, can't remember. Anyway, so she's adamant she's going home. We're like, no way, we did the home eval. I did the home eval. Porters the TV show could have came in there, bad. Called the doc, what do you want me to do? He's like, I can't hold her. I mean, we're gonna have to go to court to get this lady declared. So basically, she ended up leaving. I think Division of Family Services lady called a taxi, AMA, Division of Family Services followed her home, behind the taxi, but as far as I'm aware, for dementia in this area, we don't have a way to hold them.
No, I mean, the state of Missouri has a involuntary hospitalization process, but because you want to leave because you don't want to be in the hospital anymore, wouldn't really meet criteria for that piece of it. It's going to be somebody who's at risk of harming themselves, harming someone else, or acute psychiatric distress, that would qualify for. Now, in Moberly, there is a jury psych unit in Moberly, so there's an option to maybe make a referral if they have some struggles going on with their mental health issues and they meet inpatient criteria for that. If they're medically cleared to be inpatient for psych, Moberly has jury psych unit.
Isn't that voluntary?
It is voluntary.
It is voluntary.
Actually, they do take involuntary. They do.
Did they start?
If they have a
It has to-
DPOA.
Yeah, it has to be approved though.
What was that you said?
They have to have a DPOA. I mean, if they get down there and they refuse to stay, they ship them right back.
Yeah. And we also have to remember in terms of involuntary holds, it is, they can hold you up to 96 hours. That doesn't mean that they can bring them in, assess them, and release them because they don't think they're appropriate for hospitalization.
So I think we covered part of it, but if anyone has anything else to add to what if some of the family wishes to continue the care treatment?
Again, that is if they have if the patient's able to make his own decisions. Back into that.
But again, I would, want for those conversations to be happening though. When we start seeing the frequent flyers miles starting to rack up between us and over here, it's like, okay, you're just going round and round and round, and we've got to stop this vicious cycle and really start having some tough conversations with the family, with the residents themselves, and like, okay, let's look at your trajectory here. You've got a chronic condition. It's not going to get better. What can we do?
Quality versus quantity.
And it just needs, that conversation needs to happen often, frequently.
And it's a hard conversation
and
to
early.
have, and especially for you guys. I mean, I think the longer you're out, the easier some conversations get, but I can't imagine going in and having the conversation and you got the great grandkids sitting there and everybody wants grandpa to keep going, but maybe grandpa just needs to be comfortable.
And this is where I would say the underutilized spiritual care.
I would agree with you,
Because
Chad.
spiritual care, they're great at those kind of conversations and trying to help people sort through their thoughts and their feelings and beliefs, I'm killing grandpa or
Right.
whatever, so. it's,
Well, you get nurses that don't like to give rocks and stuff at the end because they
Kill 'em.
just, I'm gonna kill him. I don't wanna be the last dose, and they just, and maybe they've never seen someone they love go through that, but I would hope that it's somebody that I love, that nurse is able to make them comfortable in their last seconds on this earth.
Okay, so what if the family or DPOA wishes the patient go back to the nursing home?
Well, if they meet criteria, we're absolutely gonna skill them. From a therapy standpoint, I always think there's something to work on, even if it's for a week or two. And I'm sure, he's gonna even maybe qualify for some speech therapy with all the breathing issues, and if maybe there's not a swallowing issue, but maybe the speech therapist can recommend a diet so he doesn't get so fatigued and things when he eats. So, I mean, I definitely think, even though he had been bedridden at the nursing home, maybe it was the depression that was keeping him bedridden, not necessarily physicality as far as what we do, somebody walking to the bathroom with assist, or tolerating sitting up in a chair, tolerating being up because he wants to go to bingo on Thursdays. I mean, there's lots of things we can do.
And we set up the referral. Case management will go through the records to pull all of the progress notes, therapy notes, labs, and then we create a packet, fax it over to the nursing home. Once we have obtained a choice letter, it is required by Medicare that all patients have a choice. The doctor cannot walk into the room and say, I want you to go to Twin Pines. That patient has to have an option. We take a piece of paper in there that says, these are your options, and I need you to make a choice. If the patient says, you just pick one for me, we cannot. What we do is we get a hold of the family. I said, you want to talk to your family? We just need to know who you want.
How does that work if they were at perhaps nursing home that didn't have skills, but didn't have PTO too,
We
that sort
still
of
give them
stuff?
a choice.
Right, so if they switch nursing homes, is the nursing home responsible for bringing their stuff over? Do they have to find somebody to bring their stuff from the other nursing
Family
home?
typically will do it.
Family, or we
We
went
help.
places.
Yeah.
In this area, I mean, I don't know if you go even more rural than this, I can't imagine. But, I mean, every place around here has some form of skilled therapy. Now, they might not have the intensity, they might only provide 5 days a week or something like that. But I mean, they're likely gonna have something. I think Schuyler County, as far as I'm aware of, was one of the last ones in the area to get Part A services, but they've only had that in the last 10 years.
But they don't have all RN 24-hour coverage to be able to do IVs.
So, yeah, so they're, yeah, you're right, there's some give and take, might be, not be able to do a PICC line or something, so.
We would like to refer.
I understand. And we also, I mean, like if somebody's struggling, I mean, we get people all the time and they're going here, they're going across town to our competitors, they're going to Schuyler County, they're going to La Plata. I mean, that's what we recommend to people to do. I mean, this is your loved one, go tour the place.
Yeah.
Definitely take a look. Ask some questions, get some cards, call back, ask some more questions. I mean, absolutely.
It's also a time that we get, as case managers, get wrapped in, well, I normally see this primary care physician, but I don't like them anymore, and I want to see someone else. These are other things that we get involved in that we really would rather not, but we have to have a physician. They have to have a physician wherever they go. So, there's a lot of details that my girls get into.
And then at the hospital, they get really spoiled because you guys see them every day or a couple times a day. Then they come over to us and they're like, I haven't seen my doctor in 3 days.
If I don't need to be here, I can go home.
Yeah, so with the Medicare requirements, the doctor's only legally required to see them every 30 days. They have to see them within so many days of them getting there, and then has to see them every 30 days. Now, what they don't realize is on the back end, the nurse has probably been on the phone constantly or, with the doctor. I mean, the doctor is very much read into their care, but they want to see the doctor.
I guess my perspective on this is mainly just family dynamics. You can't change family dynamics overnight. But I'm hearing a patient versus a family is what I'm hearing in this. So trying to get them to talk to one another and figure out why they're thinking what they're thinking and help them come to a consensus or an agreement is what I'd probably do.
Well, and Chad, like Bev said, we start discharge planning the day they walk in our building because our goal is not to keep them. Our goal is to get them to home or whatever. So we try to meet with the families within the first week of admission at Twin Pines, just so we're all on the same page.
And in the first 24 hours, we have a discharge plan A and B. But that's not the only thing case management does. We work with the insurances, and we have a every 48-hour review of those patients to make sure that they meet medical necessity. I can tell you that last month, my staff, we have so many reviews that we have to do for each patient, and my staff completed 1,200 reviews on the patients last month. So it's very busy. That is in addition to discharge planning. So case management doesn't just do discharge planning. There's so much behind the scene that we do. And I did put out a pamphlet there. Some days I do that. Insurances are our worst. Those are, as you can probably.
Medical replacement is hard.
I have insurances that have 14 days to give me a decision if they're going to approve the patient or not. And that a lot of times comes after discharge. I just received one that we wanted to skill a patient, and on a Friday, we did not get a decision until Monday, and they denied from Friday on because they felt the patient should be able to go home. Patient was not assist, walking 45 feet, not ready to go home. No way. But that's Care Improvement Plus. I don't mind saying.
Yeah.
They are not going to work.
No.
Oh my gosh.
Well, we're going to start wrapping up soon, but is there any other services or needs that we haven't quite talked about that you think we should investigate for this patient or his family?
I guess the only thing I thought of early on is his oxygen and his BiPAP. So there are more and more hoops that the doctors are having to jump through with these face-to-faces, whether it be oxygen. A walker requires a face-to-face, any DME. So it is crazy.
Yes, it is.
So that's the only thing that came to my mind early on.
Even if a patient comes into the emergency room, or emergency department as it's called now, we cannot set up a new oxygen in the ED unless the doctor dictates patient arrived in an acute status, treated, responded, is now in a stable status, and oxygen was removed for 20 minutes after stable status, and the sats dropped below standard and therefore needs oxygen. That is the only, unless that doc dictates that out, that's the only way we can do it out of the ED. And all they needed was set up for below 2. It's getting really, really tough out there.
I guess what I would add to that, or add is, just most of the reasons why we do is not always outward. There's often the below the scene thing. And so, you have a panic attack, for instance, was a thing that I didn't think was addressed from a spiritual care perspective. So, there's a reason behind that panic attack. So spiritual care can sometimes come alongside and help give resources to help them deal with that. And usually it's not as easy as just stop doing that. And that's the same thing with anything. Stop smoking, stop, what we constantly are telling people things to do, and we know it would be healthy, but why don't we do it? Why do we stop, why don't we just, we do things we don't want to do? And it's usually because there's something below the surface. And that's something that spiritual care can often help address, is to help people see why. I just saw a patient just now, same thing, or actually it was a volunteer. I'm worried, I can't stop worrying. Okay, so let's find out what tapes are running in your head that keep you, what are you believing about yourself to keep you worrying? And if we can kind of address those, it can sometimes help. So it's just another thought for
Yeah, I just to chime in, I think it is important to look at the etiology of the panic, whether it's part of a major depressive disorder and they have some panic symptoms with that, or if it's more of the respiratory condition, literally not being able to feel that you can breathe, versus just the realization that you're at end of life and what that looks like and what that feels like, and how you experience even your family going through that with you.
Good. Does anyone have any questions? All right. Thank you guys so much.